So my name is Jay Sizemore. I'm the medical director of the infection prevention team, and today I wanted to update you on two items. The first is a policy update as it relates to laboratory testing for C. difficile infection, and the second item is the review of airborne precautions for tuberculosis. So what we've recognized over the last several years is that there's a relatively high prevalence of colonization with C. difficile that makes it difficult to sometimes distinguish disease versus colonization, especially when you're relying only on the test. These are data from a study published in JAMA in 2015. Which indicate that 3 to 7% of healthy adults are colonized with C. diff. 4.4 to 15% of those admitted to the hospital are colonized, and perhaps as high as 50% of long-term care residents are colonized. So these are people that we're taking care of in the hospital that are coming in and already have a high pretest probability of testing positive for C. diff just based on colonization alone. Furthermore, 36 to 50% of people in this study, again, hospitalized patients who tested positive for C. diff did not have clinically significant diarrhea. And a large proportion of them were also receiving laxatives. So it's based on information like these that we made a decision to change the way that we test for C. diff. So leading up through most of 2017, here at Erlanger, we were using only polymerase chain reaction, or PCR, for diagnosis of C. difficile. As I alluded to earlier, this can detect both colonization and infection, so that often results in an overdiagnosis and subsequently an overtreatment of C. difficile infection. This is a process that is often nurse-driven or nurse-initiated, and often takes place without a full review of patient factors. And so this is just a quote from a physician out in California when he says, exclusive reliance on molecular tests for C. difficile infection diagnosis without tests for toxins or host response is likely to result in overdiagnosis, overtreatment, and increased healthcare cost. So what we are suggesting moving forward as it relates to testing individuals for C. diff, we want the patient to be evaluated by the healthcare provider before implementing the diagnostic algorithm that I'll discuss momentarily. We want to assess the cause of diarrhea for the past 48 hours and assess for alternative causes such as laxatives, stool softeners, GI prep, medications with a known common side effect of diarrhea before we jump straight to C. difficile testing. In addition, we want to review the accepted definition of diarrhea, and that's at least 3 loose bowel movements in 24 hours. So they must be either liquid or soft enough to take the shape of the sample cup. We also want to evaluate for other signs and symptoms of infection, including fever, elevated white blood cell count, and abdominal pain. So after this assessment is done, if you still feel like your patient is at risk for C. difficile infection, I wanted to review with you briefly the updated algorithm, and the actual policy is available on the internet for your review if you want to further look at the details. But step 1 of this algorithm will now be to look for the glutamate dehydrogenase antigen, as well as the toxin A and B produced by C. difficile. And it's only if there's a discrepancy in these tests will an additional step 2 be done, which will be the PCR that we've done previously. And again, just encourage everyone to interpret the C. difficile test results in conjunction with what's going on with the patient clinically. Some of our testing guidelines, so we only want 1 stool sample from patients who meet criteria with respect to signs and symptoms for testing. Again, we've employed this strategy with the PCR, and it'll continue to be a strategy moving forward. So historically, there was a idea of having to send 3 stool samples. So we'll only be sending 1 sample, and if that test is positive, we don't want to retest for 30 days. If the test is negative, we will not retest for 7 days. Again, part of our existing policy. And importantly, do not send stool for test of cure. That's not recommended, and nor is it acceptable. We often get pressures from long-term acute care facilities and skilled nursing facilities who want test of cure prior to patient transfer, but we do have a letter in the policy from the Tennessee Department of Health discouraging such practice. As far as isolation precautions, as it relates to C. difficile, we do want to isolate patients who are being tested for CDI, as well as those individuals with positive results. Those isolation precautions include gloves that are required to enter the room, as well as a gown is required when there's a risk of clothing contamination. Alcohol hand sanitizer or washing with soap and water can be used upon entry to the room. However, when you exit the room, hand washing with soap and water is required. We ask that you please do not place the "Do Not Use Sanitizer" sign over the sanitizer in the room only, not out in the hall, as again, if you enter the room, it is acceptable to use the alcohol-based hand sanitizer. So the next question becomes when to discontinue C. diff precautions. So certainly if you're testing someone for C. diff infection and they test negative, it would be appropriate to discontinue precautions at that time. For individuals who test positive, it's acceptable to discontinue precautions when the diarrhea resolves. When the precautions are discontinued or the patient is discharged, we ask that you turn the C. diff precaution sign on the door over, and when you turn it over and leave it on the door, you're displaying the Clean with Bleach sticker, and that gives our EVS colleagues instructions on how that room needs to be cleaned. And EVS should always clean the room with bleach and return the sign to the nursing desk when completed. So we'll move to the second item for today's presentation, and that's implementing airborne precautions for suspected tuberculosis or TB. The sign that's placed on the door is on the left hand of this slide. What I want to emphasize is this sort of airborne precaution requires N95 respirators. So we want to minimize the other supplies that we might use for other types of isolation outside the room. So only the N95 mask is required to enter the room. It can be used for an entire shift if it's not contaminated, and we ask that both small and regular N95 sizes be available outside of each room for patients who are on airborne precautions. Sputum collection requirements for AFB to diagnose TB. So if we suspect TB, one of our goals obviously is to get the patient out of isolation, out of airborne isolation if they don't have TB. So when you order a sputum for AFB, you need to assure the patient that is in a negative pressure room or move the patient immediately. We implement the precautions as discussed on the previous slide. We then would like to collect 3 early morning expectorated sputum samples on 3 consecutive days or as ordered. So I would expect this to be the collective responsibility of everyone on the healthcare team to make sure that this gets done so that we can discontinue precautions as expeditiously as possible. Nursing should promptly notify the physician if patient cannot cough up enough sputum. Respiratory may need to induce samples, and again, delays in collecting sputum delay patient care. So how can you discontinue airborne precautions? If you have 3 consecutive negative AFBs from sputum samples, or if you have 1 negative smear from a BAL. And these need to be smear negative, not culture negative, as AFB takes many days, if not weeks, to grow. If either of the above criteria are not met, would consult infection prevention prior to discontinuing precautions unless an infectious disease physician has been consulted and discontinues. So I hope this presentation's been helpful and clarified some issues around C. difficile infection diagnosis as well as AFB precautions here at Erlanger. Thank you.